to the official group of Focus. I am Dr. Arvind Akshan. I was working as an assistant professor in Government Homoeopathic Medical College, Kozhikode. So today we are going to see the chapter on respiratory system. Let us discuss some of the important topics as well as important points regarding various chapters from the particular system. So in my notes, it will be usually regarding the notes will be presented only with the repeated questions. First of all, I'm not going to focus any questions regarding whatever this, but I can say you or I can give you the most frequent options as well as the most frequent questions and the more way of answering and how to crack the entrance. That's very important when we are focusing on our entrance coaching class. How to crack the entrance. It's not so very easy at all. Not all the idiots can crack the entrance. Not all the stupids can leave the entrance. That's the main thing you should be able to know about that. Okay. So first we can focus on the first one, which is called as ARDS, that is Acute Respiratory Distress Syndrome, or as well as in another topic it is written as Adult Respiratory Distress Syndrome. So we have two types of pneumocytes which was present in your lungs tissues. That is type 1 pneumocytes and type 2 pneumocytes. The type 1 pneumocytes, or you can easily able to identify, they are small, thin for gaseous exchange, and type 2 pneumocytes are large, thicker, and they secrete surfactant. So the important point over here is who secretes surfactants, type 1 pneumocytes or type 2 pneumocytes. So type 2 pneumocytes can only secrete surfactant. So what is the function of type 1 pneumocytes? They are used for gaseous exchange. So ARDS is characterized by rapid onset. This is very important. Rapid onset of widespread inflammation in the lungs, which can lead to respiratory failure. And they are usually triggered by sepsis, aspiration, trauma, and acute pancreatitis, severe falciform malaria, toxic gas inhalation, and lung contusion. So you all know about adult respiratory distress syndrome. Even though it is causing a respiratory failure, you can be able to calculate some of the causative factor or triggering factors, example, sepsis, aspiration, trauma. But here the odd one, you always need to know the odd one, ODD, odd one. Odd one of causative factors is especially acute pancreatitis and falciform malaria. So when you are getting an options, oh, this is not, how this will came, this won't came. Don't leave it as these two things, especially acute pancreatitis and severe falciform malaria and toxic gas inhalation as well as lung contusion too. So the inflammation process and impaired gas exchange lead to fever, shortness of breath, tachypnea, chest pain, hypotension, hypoxia, and cyanosis. So what are the clinical features that can be included in the ARDS? Options can be given below. And last, there will be a twist, especially it has been referred as except. So in except, even though there is tachypnea, and the normal output will be there, you can have hypertension too sometimes. But here there will be only hypotension. So the odd one regarding the ARDS is hypotension as well as hypoxia. So the ARDS is also known as shock lung. These are the preliminary questions, very, very simple questions. But nowadays, the NEET or IOS entrance examination is giving us a very tough questions. So read carefully and listen carefully to the class. Thank you. The other features includes pulmonary edema, hypoxemia, stiff lung, pulmonary shunting, and reduced compliance. So reduced compliance is very important regarding in your ARDS, because we are going to discuss in further more chapters. Next one is pulmonary embolism. Listen carefully, it is pulmonary embolism. The pathogenesis and risk factors of both DVT, that is deep vein thrombosis, and pulmonary edema. Not pulmonary edema, it is pulmonary embolism. Okay, pulmonary embolism centers around or Virchow-Strayer, that is the stasis of blood flow, hypercoagulability, and endothelial injury. So these three These three triad are the very important triggering factors regarding pulmonary embolism, which is stasis of blood flow, hypercoagulability, and endothelial injury. Then the risk factors include 30 years female of repeated OCP use, pregnancy, leg paralysis, and Behçet's disease. The most common cause of pulmonary thromboembolism is DVT. In pulmonary thromboembolism, there is ventilation perfusion mismatch, which is also called as V bar Q. So V bar Q mismatch is very important. So when ongoing this class, you need to write down the odd points regarding in this slides. So write down, take a paper, first written as ARDS, write down the odd point, which is falciparum malaria, triggering factor. Another one triggering factor is acute pancreatitis and toxic gas inhalation. The next point is there is hypotension, tachypnea, and chest pain and hypoxia. And then there will be reduced compliance. So these 4 points you should always keep in mind regarding whatever the questions focusing on ARDS. The some other points will be focused in the books which is called as Davidson or Harrison. Okay, so the important is you need to know about all the odd points regarding a particular questions and also the common even points regarding the question or about the chapter. So here the ventilation perfusion mismatch or V bar Q mismatch is when there is plenty of oxygen in the alveoli, but there is not enough RBC to pick up. This is called as ventilation perfusion mismatch. So ventilation perfusion mismatch is present in pulmonary embolism. We are going to study further more chapters also, but you need to write down V bar Q mismatch is found in pulmonary embolism too. So there will be asymptomatic in 70% of cases, only in small emboli. SOB means shortness of breath. A sudden onset is the most common symptom. So in every chapter regarding surgery and practice of medicine, you should always know about earliest symptom, classical symptom, most common symptom, most common triggering factor. So MC is very important. Hemoptysis, pleuritic chest pain, syncope are the other symptoms. Tachypnea, tachycardia, hypotension, raised JVP, pleural rub, pleural effusion, paradoxical bradycardia. So these are the other clinical features regarding according to the higher levels of pulmonary embolism. Here, one of the classical findings is paradoxical bradycardia. Even though there is presence of tachycardia, we have paradoxical bradycardia. This is one of the classical feature for pulmonary embolism. And massive pulmonary embolism is the most common cause of right ventricular failure. I repeat it as right ventricular failure. Okay, right ventricular failure. So this is very important. I always remember it as repertory, REP. Repertory means R for right, PE for pulmonary embolism. So I have written as in my code word repertory, REP, the short form. Okay. Now the chest X-ray shows Westermarck sign, Pallas sign, and Hampton's hump. The ECG shows sinus tachycardia. This is the most common symptom regarding pulmonary embolism, but there will be deep S waves in lead 2 and Q and inverted T wave in lead 3. So I have written as a short form for like this. Usually can be written as S1, Q3 and T3. Okay. So T should be written as small t since it is an inverted. Okay, sinus tachycardia. Sinus tachycardia, deep S waves in lead 1, Q, and inverted T wave in lead 3. So this is very important regarding your options because the options always you may get confused. They will write on as S2, Q1, T3 like that, or different options will be there. But here you need to know S1, Q3 and T3. So conventional angiography is the most and best confirmatory test. D-dimer test is not a diagnostic test for pulmonary embolism. It is only to rule out the test. M colonel sign is seen in pulmonary embolism. Now we are going to the next topic, which is called as pneumothorax. Spontaneous is the most common cause seen in tall, young, thin men. So this is very important. Tall, young, thin men. So even though he is tall, he should be tall and he should be always young. So these three factors are very important for spontaneous pneumothorax, and also there will be a history of smoking with a strong family history. So vitals are usually normal. Chest wall on affected side becomes larger and increased resonant sound. Beck's triad as arterial PB is very low, distended neck veins and distant and muffled heart sounds. So this is a very important classical feature for pneumothorax. In tension pneumothorax, there will be mediastinal shift and insertion of drainage tube in second intercostal space is the most common management regarding your pneumothorax. Then pleural effusion, fluid in the pleural space. So if the effusion is less than 3 milligram per deciliter, this 3 milligram percentage is very important regarding pleural effusion. The value is very important. 3 gram percentage, not milligram, 3 gram percentage. Then it is transudate and it is greater than 3 gram percentage, then it is called as exudates. Okay. Now, transudate is due to increased venous pressure, that is especially cirrhosis, hypoproteinemia, that is nephrotic syndrome, and hypothyroidism. So exudates is due to bacterial pneumonia, TB, rheumatoid arthritis, bronchogenic CA, SLE, lymphoma, Meigs syndrome, and pulmonary infraction. The lymphatic pleural effusion seen in chylothorax with increased TGL, which is milky in color. TGL means triglycerides level. This is a very classical feature regarding lymphatic pleural effusion. If there is any option regarding or any questions, it will be commonly focusing on triglycerides level only, whether it is increased or decreased. So most probably, and the repeated questions have been asked regarding the value. Less than 3 means who, greater than 3 means who. Bilateral pleural effusion. We also need, you should not confuse with the PE as pulmonary embolism, pulmonary edema, or pulmonary for pleural effusion. Okay, bilateral pleural effusion is seen in left ventricular failure. We have studied as pulmonary edema, not pulmonary embolism is the major causatory factor for, is the finding for right ventricular failure, and now pleural effusion we have written as we need to study as what? It is seen in left ventricular failure. So hypoalbuminemia and malignancy. So the best indicator for pleural effusion is LDH, that is lactate dehydrogenase. Regarding WBC count transudative pulmonary pleural effusion, there will be less than 1000 millimeter cube, and exudative pleural effusion there will be greater than 1000 millimeter cube. So a high level of amylase is seen in pleural fluid in malignancy. The classic triad of fat embolism syndrome is hypoxemia, neurologic abnormalities, and petechial rash. Okay. Now, respiratory failure. Partial oxygen has less than 60 millimeter of mercury with normal partial carbon dioxide is called as type 1 respiratory failure, and it occurs in pulmonary edema, ARDS, pneumonia, asthma, and pulmonary. Sorry, first one is pulmonary embolism. Oh, I always confused with that. And second one is pulmonary edema with ventilation perfusion mismatch. So the conditions which are occurring with the ventilation perfusion mismatch always have type 1 respiratory failure. So ARDS have ventilation perfusion mismatch. Pulmonary embolism has ventilation perfusion mismatch. Also pulmonary edema, pneumonia, and asthma. So the conditions which does not have any ventilation perfusion mismatch is COPD, which includes especially chronic bronchitis, then CNS tumor, myasthenia gravis, polio, Guillain-Barré syndrome, cervical cord lesions. They won't possess any ventilation perfusion mismatch. So this is very important. In type 2 respiratory failure, there will be less than 60 millimeter of mercury, as well as greater than partial carbon dioxide will be greater than 45 millimeter of mercury. This is very important regarding type 2 respiratory failure. The most common type of type 3 respiratory failure is lung atelectasis, and type 4 respiratory failure is shock. Now we are focusing on pulmonary edema, PO. There is cough, 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 spit, spit, spit. This is the characteristic feature of pulmonary edema. So left ventricular failure is the most common cause of carcinogenic pulmonary edema. And the chest X-ray shows curly B lines and A lines, the loss of distinct vascular margins, bat wings appearance on the upper above to the level of clavicle in chest X-ray. In severe pulmonary edema, alveolar filling occurs. Then inside the pulmonary edema, only encroachment of pulmonary vasculature will be occurring. Now there is chronic bronchitis. Cough, sputum production on most days for 3 consecutive months of 2 successive years. This is very important. RAID index is increased, and there is low partial carbon dioxide and low partial oxygen and high partial carbon dioxide. That is hypoxemia as well as hypercapnia. So this will be included in. There is no affection in ventilation, perfusion, mismatch, and it is also classified under type 2 respiratory failure. So their classical feature is wheeze and crackles, cyanosed, so they are blue blotters. Now chronic bronchitis, it is an inflammation of tracheobronchial tree that leads to increased mucus production, which is the earliest feature. So the increased mucus production is the classical and the earliest finding for chronic bronchitis. The chest X-ray shows dirty lungs as increased vascular markings, and chronic bronchitis is usually obese, and emphysema patients have paka weight loss. So polycythemia is an initial feature. Now emphysema, the enlarged air spaces distal to terminal bronchioles with the destruction of alveolar valves. So there are 3 varieties of emphysema. One is pan-acinar, centri-acinar, and paraseptal. The pan-acinar usually occurs in lower zone involvement and also the entire alveoli and associated with the alpha-1 antitrypsin deficiency. Okay, then diffuse lung capacity. Diffuse lung capacity is DLCO is reduced in emphysema, but it is normal in chronic bronchitis. Hoover sign which is seen in chronic obstructive pulmonary disease. Barrel-shaped chest, reduced cardiac dullness, and liver dullness shifted more downwards are seen in emphysema. This is one of the classical finding and one of the odd finding in emphysema to crack the entrance. That is, liver dullness is shifted more downwards. Then airflow limitation, hyperinflation, cachexia, and muscle dysfunction are the pathophysiology of emphysema. Pink puffer and pursed lips. So tripod position is seen in emphysema. So tripod position means a patient will sit in a chair with the limbs far apart, and as well as the elbow will be resting on both the knee joints, patient's knee joint, as we will sit in our European closet when there is difficulty in passing stool, like that position. That will be tripod position. Low vital capacity, DLCO, FEE1, FEC, and high TLC, total lung capacity. This is the classical feature seen in emphysema. The diffusion of carbon dioxide is reduced. The best initial test for COPD is chest X-ray. The most accurate test is pulmonary function test, and ECG always shows right ventricular hypertrophy and right atrial enlargement. If the FP1 does not increase by more than 12% after the bronchodilator, then COPD is the likely diagnosis of chronic bronchitis or emphysema. So in emphysema, decrease cricosternal distance, and core pulmonary as the most common complication which is seen in COPD, and there will be always barrel-shaped chest. Okay. Now it is about asthma, the episodes of dyspnea, dry cough and wheeze, the pathophysiology as bronchial muscle contraction, mucosal swelling and mucosal inflammation. So DLCO is normally as increased slightly increased. Sputum analysis shows Crushman spirals and Charcot-Leyden crystals. Low inspiration and expiration ratio is the feature of asthma. Pulsus paradoxicus, and there will be raised IgE and AEC levels in extrinsic asthma. So in intrinsic asthma, we can't able to find out any higher levels of IgE or AEC. Only intermittent asthma is better in bronchodilator therapy. In asthma, silent chest signifies grave prognosis. The last stage of acute asthma is hypercapnia, and hypoxia is the universal finding in asthma. Samter's triad, that is ST, is characterized by triad of bronchial asthma, nasal polyps, and aspirin intolerance. The atopic triad is characterized by the classical triad of atopy, which includes atopic eczema, asthma, and allergies. So this is very important regarding your Samter's triad. There will be bronchial asthma, nasal polyp, and aspirin intolerance. Okay. The microscopical features of asthma includes Charcot-Leyden crystals, Crushman spirals, and Serola bodies. Inability to speak complete sentence in one breath with a pulsus paradoxis of greater than 10 millimeter of mercury, cyanosis, bradycardia, confusion, IgE level, which always increase as seen in a triggering factor for allergic cases too. In asthma, only small airways are involved. So it is very important. That's why I have written only as capital form. In idiosyncratic asthma, Ig levels are not increased, and bradycardia indicate the most severe attack of asthma. Now, bronchitis, the chronic infection of the bronchi or bronchioles leading to permanent dilatation of these airways. Commonly affects lower lobe, the most common in left side. Congenital is Young syndrome and primary ciliary dyskinesia. There will be persistent cough, purulent sputum maximum in the morning in a particular posture, intermittent hemoptysis, finger clubbing, weight loss, anemia of chronic disease, and there will be always foul smelling sputum. Chest X-ray shows in thickened bronchial walls, that is tram tract appearance and ring shadows. Tram tract appearance and ring shadows. This is very important classical feature. Okay, the tram tract appearance. High resolution chest X-ray is the most accurate test, and is always, and it has been repeatedly asked regarding your bronchitis. The lung cancer is not a complication of bronchitis, and TB is not an important cause of clubbing. Yellow nail syndrome is seen in bronchitis. Coarse inspiratory crepitations is found in bronchitis. Middle lobe bronchitis is also called as Brock syndrome, aka is called as also known as. Okay. Then sarcoidosis, a chronic multi-system non-caseous granulomatous disorder of 20 to 40 years of age. Bilateral hilar lymph node is the hallmark of sarcoidosis. Non-pulmonary manifestations, which includes as lymph node enlargement, hepatomegaly, and splenomegaly. So splenomegaly is the only odd one which can be seen in sarcoidosis. And there will be terminal phalangeal bone cyst or seen in chronic sarcoidosis. Acute phase includes erythema nodosum, polyarthralgia, and BHL, that is bilateral hilar lymph node enlargement. Schauman's bodies, asteroid bodies, and residual bodies are always associated with sarcoidosis. ESR is increased, lymphopenia, and raised serum ACE level with the serum calcium, 24-hour urine calcium, and IgS. This is the constant feature findings for sarcoidosis. Tissue biopsy is the most accurate diagnostic test. Chest X-ray shows honeycombing, not honeycombing, honeycombing in stage 4. Cavity formation is not a feature seen in sarcoidosis. Remember that this point has been taken from Rome's textbook. Here, the cavity formation is not a feature of sarcoidosis. The 7th cranial nerve is the most commonly affected regarding sarcoidosis. Panda and lambda sign in sarcoidosis is seen in gallium scan. The ECG shows arrhythmia or bundle branch block. Lofgren syndrome, which includes erythema nodosum, joint symptoms, X-ray evidence of the hilar lymphadenopathy. Kevim's test, that is intradermal injection of a sarcoid spleen extract. The chest X-ray shows eggshell classification of hilar nodes. Giant cells often contain inclusion bodies, Schumann bodies, asteroid bodies, and residual bodies. We have discussed it earlier point too. So the first column as disease and second column as source of infection. So silicosis is due to SiO2 silicosis inhalation. Farmer's lung, which is called as moldy hay. Bagosinosis is avian dropsing. Biosinosis is sugarcane dust, or which is also called as Monday sickness. Malt worker's lung is by moldy barley. Miller lung is due to infested wheat flour. Meniscitis is coal dust, and tuberculosis is called cork dust. Now, interstitial lung disease, which is progressive interstitial fibrosis. There is honeycombing pattern. In honeycombing pattern is also seen in sarcoidosis, which is in stage 4. Here, honeycombing pattern and ground glass pattern is seen in interstitial lung disease, which can be highly evident in high resolution chest X-ray only. Sorry, computerized tomography, CT only. TB is not a factor, but exposure to cobalt can lead to interstitial lung disease. The best initial test is chest X-ray and HRCT, and the most accurate test for interstitial lung disease is lung biopsy. Idiopathic lung fibrosis. The dry cough is the most common symptom. Type 1 respiratory failure is the most common complication for idiopathic lung fibrosis, and this can lead to ventilation perfusion mismatch. Finger clubbing and fine end inspiratory crepitations are the classical signs for idiopathic lung fibrosis. Restrictive pattern is seen in spirometry, and raised CRP is the classical feature for idiopathic lung fibrosis. Silicosis, it is caused by inhalation of silica particles, progressive dyspnea, and higher incidence of tuberculosis. The chest X-ray shows diffuse miliary or nodular pattern in upper and mid zones and neck cell calcification. The CT scan shows characteristic crazy paving. Restrictive defect in spirometry, also associated with a calcific hilar adenopathy. So this is a common factor which is seen in silicosis. There will be progressive dyspnea. The progressive dyspnea is the main factor. Among the interstitial lung disease, silicosis only possesses the higher incidence of tuberculosis. Not any other occupational lung disorders or interstitial lung disorders won't possess tuberculosis. Example, other than sarcoidosis, asbestosis, biosinosis, bagosinosis, everything. But silicosis has only to possess the higher incidence of tuberculosis. This is a very important, and this is the only odd one point most regarding your occupational lung disorder. Then coal workers pneumoniasis, it results from inhalation of coal dust particles, and this causes fibrosis. The chest X-ray shows round opacities, especially upper zones, and progressive massive fibrosis causes core pulmonary. So core pulmonary, that is your heart failure. This is very important regarding your coal workers pneumoconiosis. Kaplan syndrome is associated with rheumatoid arthritis, pneumoconiosis, and pulmonary rheumatoid nodules. Now, asbestosis. Inhalation of asbestos fibers with the ferruginous bodies. Malignant mesothelioma is always present. Finger clubbing and recurrent pleural effusions is present in asbestosis. Obstructive sleep apnea. The breath cessation for at least 10 seconds. Obstructive sleep apnea is the most common disorder, causes daytime sleepiness. And the complication of obstructive sleep apnea is pulmonary hypertension and type 2 respiratory failure. Night stroke respiration is seen in obstructive sleep apnea. Weight reduction is the only management that can be advised or that can be given to the patient with the obstructive sleep apnea. Pneumonia, a community acute pneumonia which occurs within 48 hours of hospital admission with Streptococcus pneumonia is the most common symptom, and Streptococcus aureus is the second most common symptom. Trachea is centrally placed, but diminished chest expansion, dull percussion note, and tubular bronchial breathing with increased vocal fremitus is the other classical features for pneumonia. Hypoxia and hyperventilation are the factors of ICU admission. Rusty sputum is seen in pneumococcal pneumonia with the chest X-ray shows lobar consolidation. This is a very important point. Staphylococcal pneumonia occur in children, may complicate to influenza infection with the chest X-ray shows cavitation. Klebsiella pneumonia with red currant jelly sputum with the affection of upper lobe. Atypical pneumonia with a dry cough or non-productive cough which involve interstitial space and hence very less sputum is a classical feature for pneumonia. Legionella pneumophilia with a dry cough, diarrhea, confusion with incubation period of 2 to 10 days, and chest X-ray shows bi-basal opacity with lymphopenia, hematuria, and urine antibodies. Mycoplasma pneumonia occurs in epidemics with a dry cough, and chest X-ray shows bilateral patchy consolidation. Anaerobic pneumonia with the foul smelling sputum, and the chest X-ray is the best initial test for lung abscess. Type 1 respiratory failure is the most common complications in pneumonia, and raised TLC and ESR are the other features. Bronchitis sicca is seen with the tuberculosis. Kurth 65 score, that means confusion, urea, respiratory rate, and blood pressure and age. So around the age 65, there occurs confusion and urea above 7 millimole, respiratory rate above 30 per minute, and blood pressure with less than 90/60. Then the Kurth score is very important factor for to find out the Kurth scoring. It's very important. Okay, for pneumonia too. Then around pneumonia and community acute pneumonia is seen with the Streptococcus pneumoniae. In pneumonia, severity scale age is the most important factor than hypothermia. Then H's pneumonia is typically seen in measles. Bronchopneumonia affects children and elderly. Red hepatization includes presence of erythrocytes in the cellular intra-alveolar exudates. And gray hepatization occurs, there are no erythrocytes, only neutrophils is the predominant cell regarding in your gray hepatization. The major cause of pneumonia in young adults is mycoplasma. Important protozoan causing pneumonia is Endamoeba histolytica. Lipoid pneumonia is caused by creosote and petroleum products. Bulging interlobular fissure is a characteristic finding in Klebsiella pneumonia. Splenomegaly is the classical finding in viral pneumonia. Cavitation is found in Klebsiella and Staphylococcus pneumonia. WBC count raised in all pneumonias except Legionella. Okay. Then cystic fibrosis, it is one of the autosomal recessive disorder. It affects respiratory system, genitourinary system, and GIT. Staphylococcus aureus in children and pseudo aeruginosa. Sinusitis with chronic cough and greenish sputum, breathlessness, and hemoptysis. Digital clubbing is present in feature of cystic fibrosis. Late onset puberty and infertility is the other feature. Salt depletion syndrome with increased sodium, sweat in sodium and chlorine concentration. Biliary cirrhosis, steatoria, and meconium ileus are the other classical feature for cystic fibrosis. Now the points regarding pulmonary function test, that is TLC, that is the volume of gas contained in the lungs after normal inspiration. Residual volume of gas in the lungs after maximal expiration. Vital capacity, volume of gas that is exhaled from the lungs going from TLC to RV. And TLC and RV always, that is total lung capacity and residual volume, always determines the obstructive and restrictive, which means increased in obstructive and reduced in restrictive. This is very important point, and means whenever total lung capacity and residual volume are increased, then it is a form of obstructive form. Whenever it is in reduced form, then it is called as seen in restrictive form, RR and IO. Then vital capacity is decreased in both obstructive and reduced. So this is a simple one to easy calculate. Interstitial lung disease, pleural pathology, chest wall deformities, and neuromuscular diseases are the common causes of restrictive pattern. And FE1 ratio to FVC ratio is less than 0.70. This is the diagnostic of obstruction. So this value 0.70 is very important regarding our it's very important to calculate this ratio. So anything that is less than 7.0 also very important. Normal or greater than 7.0 is very important. So this value is very important, 0.70. So DLCO is increased in pulmonary fibrosis, anemia, congestive heart failure, pulmonary arterial hypertension, and emphysema. And DLCO is increased in Good-Pastor's syndrome. Peak expiratory flow is the normal maximal forced expiration through peak flow meter, and it correlates with the FE1 in 1 second and measured in asthmatics. Reduced static compliance indicates in interstitial fibrosis, atelectasis, pulmonary edema, pneumonia, and ARDS. Increased static compliance indicates emphysema. Okay. Then tuberculosis. Primary tuberculosis is the first infection with the tubercle bacilli who have not been previously exposed to the organism, seen in children via inhalation with affection of middle and lower lung zones. Primary focus is known as Ghon's focus, and Ghon's complex is equal to primary focus plus involvement of regional lymph nodes. The Ghon's lesions plus ipsilateral calcified hilar lymphadenopathy is called Rangi's complex. The pleural effusion is common in primary tuberculosis. This is a classical feature for tuberculosis. Pleural effusion, which is common in primary tuberculosis. Cavitation is not a feature of primary tuberculosis, but it is a feature of secondary tuberculosis. The best initial is chest X-ray, and bronchial arteries is the most common source of bleeding in hemoptysis, and is greater than 90% of cases. A shock index syndrome, this is very important. The shock index is a calculation of heart rate plus or bar systolic blood pressure. Seal-Nelson technique, where bacilli or numerous in sputum culture, this is one of the classical findings for tuberculosis, and ELSA test for IgG antibodies. So cavitation is cavitary lesion is the most infective form of tuberculosis. Rich focus is present at the meninges, and the most common presentation of primary tuberculosis is unilateral hilar lymph node enlargement. In miliary tuberculosis, Mondrax test is negative. The cavitation formation is not a feature of HIV. The commonest feature in Panson's disease is joint pain. The Pancoast triad includes shoulder or arm pain, Horner syndrome, and atrophy of hand muscles. Okay. Then we are focusing on lung tumors. That is, adenocarcinoma of lung is a malignant tumor with a glandular differentiation or mucin production, about 80% of tumor cells. Small cell lung carcinoma is present as central masses. Cigarette smoking with release of ACTH, ADH. Cough is the most common symptom. Clubbing, especially grade 4, that is hypertrophic pulmonary osteoarthropathy. Superior vena cava obstruction that causes Horner syndrome, and low serum sodium plus raised ADH. Okay, these are the features for SCSLC. Recurrent hemoptysis is the most common presenting of bronchial edema. Mesotheliomas are not associated with the smoking and it is present with the pleural effusion. The most common primary bronchogenic carcinoma is adenocarcinoma and it is not about SCLC. The most common type of primary CA lung in India is squamous cell carcinoma. Okay, this is very important. The lung-to-lung metastasis is most commonly seen in adenocarcinoma. Clubbing is the most common factor for small cell carcinoma. The most common cause of mediastinitis is esophageal rupture. Leptospirosis, hantavirus, and paraquat poisoning are the causes of pulmonary renal syndrome, PRS. Pulmonary fibrosis seen in thickening of pulmonary alveolar capillary membrane too. Okay, so these are the important chapters or the important points we have come over. Different topics of respiratory system. The remaining portions you need to read with a classical book. If you are focusing on Davidson, please read all the tabular columns from the respiratory system from the beginning to the end. Read all the notes or all the points which have been described in box form. Okay. Sometimes it can be asked in a very detailed manner or very tough. Sometimes it will be asked in a very easy manner. Cracking the entrance is very important. So always write down a simple, take a simple paper or take a note and write down the simple points or have a classical idea about the different topics or different disease conditions. Then you can able to write down or work out the questions very easily. Okay, thank you. Thank you once again and see you soon.